All right. Hello again, everyone. I know that folks are still getting settled and perhaps filtering in from outside. We do have a very important timeline that we need to keep, and that is the fact that our cocktail reception does start at 5 o'clock and may be ready as early as 4:45. So in order to make sure that we have a timely journey up to the cocktail reception, I do want to make sure that we get started here relatively on time. So we do have one final panel for the day on patient access use cases. And we heard a little bit about the patient aspects of FHIR, but I think it's worth a deeper dive from those who are directly supporting the patient's permitted purpose in our terminology, patient use case as it's commonly referred to. I think it's very useful to hear from those folks, and that is exactly who we have on this panel. And I'll turn it over to Dr. Michael Hodgkins from the AMA to introduce his co-panelists here.
Thanks, Dave. Saving the best for last. We have a very interesting group of speakers today, all of whom are involved very directly in patient access solutions. And I'm going to let each of them introduce themselves. They also have a personal story to tell that really is something that has inspired them to be involved in this area, which I think we should all recognize as particularly important. As a physician, I recognize it as important because I know that what I do in a clinic probably only accounts for about 30% of ultimately what will happen with a patient, especially a patient with chronic disease. And the rest is really largely up to them. And if they don't have access to the right information at the right time and insights around that information, then I don't know how they can be successful. So I think what our panel has to tell us today is as important, perhaps more important, in fact, than what happens in the clinic. So with that, I will ask each of them to introduce themselves and make some brief comments, starting with Ellie.
It's absolutely great to be here. And everybody wonders, what can Carequality do for me? And if you look up on the board, oh, it's actually just taken down, but the picture that was supposed to be me, Carequality actually saved me about $13,000 in getting a hair replacement treatment. And they put up a fabulous picture of somebody. I think it was the last presenter. I was only in the room for a few minutes. But I'm going to actually forward that to my wife right now while I'm sitting up here. The wonders of the Apple Watch. So,
Apple.com should be able to answer that question.
That was funny. I said the wonders of the Apple Watch, and it just answered. I'm back on stage over here in Carequality, looking around the room, recognizing quite a few of you, and I'm excited to be here. I wear two hats, and one hat's my business hat, and one hat's my everything else hat. And Wamba has allowed me to merge the two hats into really how I'd like to spend the rest of my life figuring out how we can be champions of consumer access. Wamba is part of what's called the World Medical Bank and stands for a World Medical Bank account. And as a founder and CEO of Wamba, our goal is to be able to put the power back into the patient while leveraging everyone in the room and all the wonderful traits, abilities, and the depth of the Carequality members, implementers, and contributors. That you know my story, I'm a New York City paramedic. Those of you who do or don't know, EMS in New York City is part of the fire department, so if you ask me if I know what a fire engine is, I'm absolutely well qualified to say yes, as a paramedic on a fire truck sometimes. But outside of that, I don't have a strong IT background, but I have a strong desire leveraging my experience as a paramedic and my 25 years as a commercial pilot. Our team ends up in many, many, many disaster zones, including as recently as last week, being in Panama Beach and Mexico Beach and seeing absolute disastrous catastrophe the likes of which you can't really appreciate sitting here knowing that we're a mere 1,000 miles away from homes that are just completely crushed and gone. And you see people walking like zombies in these zones, whether it was Houston, whether it was Key West, where I've been in Haiti, and our team's really been privileged to play an incredible role in many disasters. But as a New York City paramedic and a volunteer paramedic, you realize that to the family, to the mom, to the child who's hurt, that disaster of one is oftentimes devastating and crippling. And when you compound that on the fact that it's such a struggle to be able to share data from one place to the next, I've made it my life mission to be able to help the consumer access the data with your help in the audience. And today we're going to discuss part of how we'd like to see that improve and make something good into a great thing.
Thanks, Ellie. Jennifer, you want to go ahead?
Hi, I'm Jennifer. I'm the co-founder and CEO of One Record. One Record is founded by myself and a friend from college, and it's a vehicle to let people access and aggregate their data. The reason why we started the company was because my friend Morgan, who's actually supposed to be here on this panel today but couldn't make it because of her health, had a really hard time getting diagnosed. She looks Caucasian, but she's South Pacific Islander. It was probably over 2 years before somebody was like, wait a second, you have this disease. And it was because she was being sent to the Mayo Clinic and she had collected all her records in a binder and she was preparing to go and she had a cover letter that someone actually looked at her basic information and then kind of put the pieces together and did the test. So the reason why we founded One Record was we were kind of looking around at all the apps in the App Store, we were looking at anything online, and nothing really worked. And being a patient is a full-time job. And we're part of Carequality because I think it's the vehicle that's going to get to widespread adoption of access to medical records for the patient.
Bart, go ahead.
Okay. Good afternoon, everyone. I'm Bart Carlson. I'm the founder and CEO of Azuba Health. And the reason I started Azuba Health, I'm kind of a technology guy. I've been kind of a serial entrepreneur. And about 6 years ago, CMS asked me to be on a committee to look at Blue Button. And before that, I never had any idea what Blue Button was until I got to the first meeting. But essentially, it was trying to empower consumers with some access to their data. And the focus of Blue Button was on basically on claims data. And that meetings went on for about 1.5 years. And at the end of that 1.5 years, I went around and talked to all the other people in health, and there were 66 people in health, and I was the only one on the committee that wasn't from health. And I couldn't find one that said that they were going to solve the problem that all of us on the panel here today are working on and dedicated to doing. And so I was actually a little bit down. You know, I was like, okay, we did all this work, we came here, and nobody's going to focus on this. And so I went home, I told my wife about it, and kind of thought about it for a while, and a few months later I said, I really wasn't planning on starting another company, but somebody has to do something about this. And so I, formed a company, went out and tried to learn as much as I could over the next year by attending all the conferences in health, hiring a firm in California to help me do the research on what was actually, over the real numbers behind the health scene, what were the problems that patients getting their records and things of that nature. And after about 1 year of doing that, I decided, okay, this is really a go. And so I started to design a system that would empower the patients with their data, and also found out about, Carequality. And so 2 years ago, started developing the system, and have been working on that ever since. And, I tell a story, and it's about a friend in the name of things. But one of the things I think all of us are up here and everybody else in the room, so this is going to be, probably an audience that already knows this, but it's a story about a friend's daughter who has cystic fibrosis. And I know you probably can't see the sign up there, but her name is Carly. And just imagine if it was your daughter, Carly, who had cystic fibrosis. and all the things you would do to try to help her get well. And so, just like I'm describing, the parents of Carly took her from doctor to doctor to doctor. And their stack was much higher than the stack I have here today, because I didn't want to carry on more on the plane to get here. But after knowing what's happened in other industries, the banking industry and so on, and some of the things we talked about back in the blue button days, it seemed to me that we need to do that. I saw Carequality and Sequoia as an opportunity to come together with others who were like-minded and to be able to solve that problem, and to be able, instead of carrying in a stack like this to the next doctor for Carly's appointment tomorrow, to be able to push a button on whatever app it may be, whatever system it may be, and have that delivered to the doctor in a form that's usable for the attending physician. And so the whole idea was to go away with a smiling Carly, with now physicians having the data to be able to make a better diagnosis and better treatment plan based on a whole bunch of other things that were bothering Carly. So glad to be here, and looking forward to our discussion today.
Well, so why don't we get right into, since this is the Carequality portion of the meeting, and talk about the access use case. And I'd like to get your thoughts about it and how you intend to use it, but also what you think are some of the obstacles or challenges to actually making it possible to advance what you're doing through that use case.
I can start. So Morgan and I built one record, and we've been beta testing this whole year with real patients. We do it through multiple different cities. And I can't talk about other people's accounts, but I can talk about Morgan's account. She's able to get data in real time. It actually surprises me how much quicker she could get data, because I usually think a doctor has to wait, close the note, then it has to be submitted, pushed. But when you go into her account and you see all the files, and they're all coming in CCDAs right now. We are FHIR enabled, but we're predominantly bringing in CCDAs through Carequality. We're also live on Commonwealth, so we're working with both networks. But she gets these records, they come in, there's a lot of data. And then we run it through a deduplication and aggregation process to create that longitudinal health record. And it creates a lot of value for her when she walks into the doctor's office and she has this trending history. She can talk about things that she's done and started medication-wise, past procedures, and it changes the dialogue for her. So I think that, being in health IT at this point in my life and looking at the space and thinking about where we need to go, this is a perfect moment to kind of push this use case forward. And I think that the framework that Carequality offers is a place to develop it.
You must be a politician, because he asked what the challenges are and you just complimented it. So that was well done, and I think
No,
He started with...
I said, tell me what your thoughts are about it, and then also what the challenges are.
Do you want to hear the challenges?
No, but
I can tell them to you.
But I think you couldn't have said it better. And Carequality takes those challenges and has created a framework and a roadmap for dealing with the challenges. But so you've given compliments, and I want to recognize Dave, Katie, Jen, Dawn, and Jay. I think you guys have done an amazing job here, and in general, Carequality's amazing job. But I think the challenges are in the process. The challenges start at the patient level, and the challenges start at what's real on the street and where do we really want to end up being. And I think it's multifocal. I think patients don't know their usernames and passwords. Patients sometimes don't even know which facilities their doctors are part of. Patients almost never know which EMR, their hospital, that their doctor is part of, and exactly what the username, what the website, where they have to go. And when they finally figure all that out, the amount of data that's available through a patient portal to the patient is clearly not a substitute for the pile that we have on the table in front of us. So the challenge first needs to be recognized that we don't have a true replacement of that medical record file in any sort of comprehensive, complete packet that exists today. And if we do, the only way we're going to be able to bridge that gap is when all of us in the room recognize that, hey, the records that once upon a time were thought to be owned by a hospital, by a technology company, by a doctor, by a clinic, ultimately, we as consumers, I don't even want to call us patients, I want to call us consumers, should have, and I personally believe we do have, what's called the consumer right of access to make us either directly or through proxy the owners of our records. And my day job for 28 years has been running probably the largest data aggregator in the United States for insurance companies to be able to do underwriting on the front end and on the back end. That excites me far less than during an emergency of epidemic proportions or an emergency of one, or simply navigating your way through that whole process of an illness or an injury, or frankly just being able to, get your child's school immunization records, or a camp, physical records, or the constant duplication that happens when you go from one doctor who changes a network or changes an insurance plan to the next. The challenges are huge, and we together can clearly, those of us who represent three, forward-facing companies in this space, and all of you who represent the data and the ability to transmit that data, we can solve it by putting it together into a consumer-facing app. Now, the beauty of FHIR, and I know FHIR stole some of our talk during the last talk, so I'm going to talk for 1 second about that, is not always do we want to share everything in our file with somebody that we go into. You can't walk down the street without seeing an urgent care center on every corner. If I went into an urgent care center because I had a Q-tip, got stuck in my ear, doesn't mean I want to be able to go and share anything else that's not related to perhaps my immediate issue. My history of the present illness is one thing, but my past medical history doesn't necessarily always get shared. But there are many, many times that I do need to access that. So being able to break our file, access it, and then choose who we share it with is clearly a challenge, and I think FHIR and the Carequality partners that are all sitting in this room can overcome that challenge. And I'll wait, but I certainly feel that all of us over here need to identify the challenge of making sure that the records that do get shared are appropriately requested, and certainly that the records that are delivered are appropriately delivered, and we'll share some talk on that shortly.
Bart, did you want to comment on this?
Well, first, I agree with what's been said by my two fellow panelists. I think one of the things that Ellie was talking about there at the end is very important, in that putting the patient at the driver's seat, to be able to share with who, what they want, what time period, what records. And that's kind of key to bringing the patients into what I call the triangle of health. We all know how important providers are and the payers are, but we also believe, I think the three of us, is that the consumer or the patient, if you will, is an important part of that. And if you look at the whole spectrum of health, a certain part of it is all of the things that the providers do for us on a global basis. But there's another part that the patient has to take control. And so getting their involvement by using the kinds of solutions that the three of us represent up here with the Carequality backbone and partnership is a way to bring those patients into the equation on a day-to-day basis. So when they leave the doctor's office or the emergency room, they have access to what they need, not only for that particular visit, but for whatever the cumulative visits may be. And if there's parts of it that they want to keep private because they had something along the way that they don't want to share, the ability to control that on whatever the case may be.
I think that the biggest barriers at this moment in time is that there aren't enough endpoints lit up within Carequality for this specific use case. And I think a lot of that has to do with how do we authenticate the user, and also on the, the site of the side of the system or the provider, what risk level are they willing to take when they're getting a patient-initiated query? I think that that is the role our three companies get to play within Carequality, and I think that's the role of Carequality to create that framework so that it is a trusted community, because we are seeing so many apps pop up, but think about Facebook and everything with those third-party apps accessing your data and then pushing it out through that way. In healthcare, it's much more sensitive, and I think the user is much more aware of their data being sold and transacted, and people do want access, but I think that's the value of this group, is to create the framework so that when a system gets the query and the patient wants to pull in their records, that they accept it.
There was some discussion yesterday in a separate conversation I was having where we were talking about, on the one hand, having access to the data, I think we can all agree, is a good thing. On the other hand, there are questions about the quality of the data, what really is accessible, certainly in any standardized way or in a digestible way. What have you guys encountered, and how do you address that?
So, for starters, I think that I'm going to go out on a limb and say that everyone in this room would love to see as much of the data get delivered, but the hospitals or the doctors or the final endpoints are just not necessarily agreeing to a use case that's been approved, and they have the option to say, yes, I'd like to go ahead and share or not. And within that, sometimes too much data is almost as much of a problem as not having enough data. And when you get data as an end recipient, i.e. a consumer or a patient, you need to be able to take that data, standardize it, and then present it in a very visually pleasing and easy manner. So that's not just for you. That's for if one of us are a caregiver for elderly parents, or we're a caregiver for children, and we have the ability to look after individuals. We want to see our own medical records put in a way where walking into that urgent care center, you're not spending a half an hour answering questions, and the doctor's not spending a half an hour asking them. You can just drill right down to the point. You want to be able to look at overlapping data from multiple different facilities, multiple different hospital health organizations, multiple different EMRs, even perhaps multiple different countries, and be able to look at that data in one simplified format. So these are challenges that we identify as the vendor, but I'm going to go out and say that we'd like you to influence as much as possible your individual healthcare facilities to subscribe to the notion of sharing that data back with the patient.
So with the CCDAs, there's a lot of different variations. You see some really funky ones come through. You see ones that are really nicely formatted, very clean, very nicely documented. There's ones I don't even know how they pass certification sometimes. And I think it's our job as applications that are focused on consumers is to present that data in a way that's very digestible and that they can interact with it. I'm not a data scientist, and I have a really hard time kind of with graphs and really understanding data. But if you do it by leveraging best-in-class UX and thinking about all the different types of people who could be accessing their data and how they want to use their data, that's the job of our applications. And I think the job of the health systems and providers where the CCDAs are being created, we can't control that. So for us, at One Record, we run the data through a deduplication and aggregation process, and we only bring in data if it's 100% match. And we are only working within the fields of the CCDA. It's a different flow for our FHIR flow, but within the CCDA that we're getting from Carequality, there's only so many fields that we're representing at this point.
Just, it's kind of funny how we all come in from different backgrounds and perspectives. And one of the things that I've been doing for the last 30 years is spending 2 days a year going in for an executive health checkup at Mayo Clinic in Rochester, Minnesota. And they collect a lot of data, and one of the things at the end of it they do with us as patients is they show us the results. But it's not just the results from this 2-day visit. Depending on how long you've gone there, it's for 5 years or 10 years or 15 years or 20 years or in my case 30 years. And that has kind of turned the light on to me that the more data you have and over the longer, because I don't understand all the data because I'm not a physician. I'm, was not trained in health, but I do understand graphs. And if you tell me that the graph is going up and that's bad, I better pay attention to what my primary care doctor there is telling me. If the graph is even or it's going down, guess what? Nice job, Bart. You're doing something right. You don't have to pay attention too much to what that is. Just keep on doing that. So that's kind of like, one of those things that happens on our journey of life. You get these little data points. And after I began to get into this and understand all the things, frustrations, if you will, sometimes with getting in data that may not be the most structured, the most, not the cleanest data or whatever, how important cleaning that data up and putting it in and then being able to share it back with patients like myself in some kind of graphical form. And I think that's what we all bring to the table here collectively and looking out for the patients with the Carequality team, being our backbone here to bring in that data.
So let's talk about your wish list. You've got an audience of people here, all of whom are involved in Carequality. I'm sure, how many implementers in the room? A lot of implementers in the room. What do you want from them? Why don't you tell them what you want, what you need, what you hope for?
I have a pretty long wish list, and the only thing between that and the drinks is going to be me. So I'm going to really shave it down to a couple of core points. So firstly, I want to say that a wish list would be for us to have to go out to less endpoints to get that data. And kudos really to this new hub that we heard about during this conference, between Carequality, eHealth Exchange, and obviously with Commonwealth as well. True interoperability will ease a lot of our concerns. I think the ability for us to agree on a standard by which to make sure that we're comfortable identifying who the patients are and have that continuity of identification from the time they make an initial point of contact with a provider through the delivery back into our environment would be a true realization of a dream for me. In our company, as an example, within Wombo, we have a product called Me Only, which is revolutionary and forward-thinking, but I'd love to be able to sit here at next year's conference and look back and see that whether it's our product or a similar product, we do biometric authentication using picture ID government issued against liveness detection against various different points of data, and we carry that biometric against the various components to identify and to be able to carry through that process. And the wish list is really that the data is not held back, but the data is readily shared with the patient so that we can all be successful in our goal of knowing that true interoperability exists when an HIE is created, and what I'd like to think of in our Wamba world, an HIE of one, because I've never been to Kaiser in Sacramento, and I've never been to Hackensack in New Jersey, so I don't want to sound selfish, but I don't really care whether those two hospitals communicate with each other in the event that I have to worry about something for one of my children. But what I do care about is that my pediatrician and the local hospital and the local doctor, they all communicate. And without the ability to share the data back and to share the richness and the full integrity of the data subset, we're not quite there yet. So I'm hoping everybody in the room can appreciate that on a personal as well as a macro scale.
Jennifer?
So I know there's a lot of competing thoughts out there about data access, whether it's a vendor or it's a health system. And within this context, within this space, I think the thing for everybody who's a participant in this room is when the advancing patient queries work group suggestion comes to be voted on within the Carequality Connected Agreement. It's going to take everybody to participate to make it happen. So I think that's on my wish list, that we move towards that direction where your clients are accepting the patient-initiated queries. And then we can't control everything, but if you look at the fire flow and OAuth and how it's just using the patient portal credentials and the current flow we're using here, data is going to flow either way. So I think we should kind of move in the direction that we're ahead of the curve.
I think those are great wishes, and I would support those. I think one of the things, just as an organization, that we might want to consider from my wish list would be, I think we're doing pretty good on pulling in providers. We're very good at pulling in, the vendor community. I'd like to see, more of the payer community being involved here, because I think they're part of that triangle of health in the United States. And so when we're having, meetings, we have their point of view as well as the patients that we're trying to bring here and represent, as well as all of the, wonderful providers that are part of the group. I think going forward, those things are going to naturally happen as we continue to extend our arms out and reach out to our other networks and other things. And I would just like to see, that complement to come in here as part of the total triangle of the solution.
I have one more wish.
Go ahead.
I'd like to see improvements on ID proofing. So I'd like to see more companies popping up who are just working on that problem and offering better solutions.
So earlier, I asked for show of hands on the implementers. Put your hands up again. Implementers. Come on. Don't be, there's more of you out there because there were more hands before us. Put your hands up.
You're getting tired.
Come on. Okay, so how, keep your hands up if you support the use case that we're talking about today. You're putting your hands down. Why'd you put your hands down? Well, you put your hands down.
I put my hand down because universal access to data poses a risk, and that is these three are great people. I can trust them. But that guy over there that's invisible, that wants to steal the patient's health ID and gets universal access to data, that's not good. And if I'm a hospital and I granted access to that data, who do you think is going to be sued? Me, the hospital. So we need a safe zone. We need some way of providing data while keeping it safe and secure.
Go ahead.
We're already mandated today to give open access to our patients and their own access to that data through FHIR interfaces. So I completely support the idea of delivering patient data to the patient at the patient's request. And I'm tired of the old adage that there is somebody that's going to come after us for a privacy issue when the patient has actually requested the exchange. And I think we need to actually have a true conversation in the communities about open access when a patient requests it.
I think that's fabulous, but we should bring you up on stage over here. But I'd like to address the question, and the question or the comment, which is the concern about the hidden shadow requesting the wrong set of records. To answer that, I think I'm definitely an industry expert, because after requesting millions and millions and millions of records over the last 30 years, I could tell you that the current process, I hope I'm allowed to use this word, sucks, okay? Because today, to get your records, I would have an extremely easy time. I'd just write your name on a HIPAA authorization. Your signature would look something like this. I hope you got that on camera. It would look like that. And then your facility would likely release your records. I don't profess to be an expert on what my colleagues, Jennifer and Bart's systems look like, but I can certainly assure you that if they're sitting up here representing the public and community at large, they will take many, many, many steps to assure that they have validated in a much, much, much richer and deeper environment than is possibly even remotely thought of today. And yes, if you want to be a fraudster, you'll always be able to mimic or somehow beat the system. But the system today is severely lacking in its ability to identity proof, to make sure that the right patient is there. And with advances in things like biometrics, like authentication, comparisons against liveness, against government-issued ID, things like getting notarized documents. There are many, many ways that we've looked at the current problems and said, let's make it better, that if all of us together say, we're happy with that process, or we'd like to move forward, but we want to do it in a very safe and secure manner, we'll do that, and I promise you it'll be a lot better than it is currently.
That's why we're here. I mean, there's an actual audit trail. Like, we've gone through the measures to get certified to even participate in this space. So, I mean, for us, what we're doing security-wise, like how we're hosting, the levels of compliance, and then everything, we're going above and beyond. And then when anybody gets a query from us, they're going to know it's from a trusted application, and then it's going to ping wherever it needs to go. So there is an audit trail of where the data is going. So at the end of the day, it is the user's choice to request their data through our application. We're just the vehicle to do it. And the next generation is not going to tolerate the current workflow. It's just not going to happen.
Look, we're all consumers at one point or another. We're all patients at one point or another. How many of you want a right of access to your data? Okay.
Come on, lift your
How
hand.
many of you have actually accessed your data using an app or portal? Okay. How many of you are comfortable with that process? How many are uncomfortable with that? Pardon me? No, how many are uncomfortable with that process?
It's a great point, the holistic picture from a patient's perspective. Don't forget, everyone in this room has got some real exposure to the world of medical records, the data flow. The average patient has none of that. It's scary, it's difficult, it's expensive, it's cumbersome, it's time delaying to the tune of sometimes weeks or longer. And then when you finally get it, you get a siloed approach. When you are able to access an individual facility's records, it's a watered down system. Even the better ones are not giving a fully comprehensive environment. So what we're suggesting is that we start with security, we start with validation, we start with making sure that all the I's are dotted, the T's are crossed, and we work together with everyone, because your spouses, your kids, your parents, they're part of that everyone, and would like to help you as well as help anybody that needs the help.
Questions?
May I comment?
Okay, dead on. Because how many of us have all of our patient health care from one facility? Probably nobody's going to raise their hand. So if I need my comprehensive health record, I have to log in to individualized patient portals, pull that information out, put it in a Word document or something like that, combine it together, or just stack
And that's what Carequality offers, that opportunity to do that. And to address your point, I see totally different data quality if you're going through the patient portal and downloading what's available versus what you pull in even through a FHIR call versus what we get through Carequality. So there is good data available to the user, and it's just an evolving use case. And I think I totally agree with Wamba. We're starting with security, authentication. Like, that's the key, because cybersecurity, like, that's the growing field, and I think we're moving that way. And then data just being available, that's the other direction, and I think we're going to get there. I'm already seeing it, so I'm a believer.
Well, you know, since the term of art has been deployed by Ellie here, you know, from what I've seen of many hospital and large system security, it sucks. And I'd put my trust in these guys over many of the hospital systems that I've seen in terms of what their security protocols are and their ability to keep unwanted intrusions out of their system. Having said that, that's my opinion. It's an editorial comment. Any questions? We've got 3 experts up here who are struggling with this. Any questions for them? Yeah, go.
Rob. Hi, Rob. I have a question for you. I think, Jennifer, you mentioned you have FHIR, a pathway to FHIR, and you also mentioned CCDs or CDAs. We heard from a panel earlier today about the document content and now having more content. Is there also work within the Carequality framework for the content? Because you talked about the patient access, not requirements, but there's something coming out that we should all be looking at. Does it also look at the content that implementers might want to consider? And do you like the FHIR stuff more than the CCDs, or just anything, get everything, encounter summaries? How do you approach that?
I thought the earlier panel this morning when they were talking about, it was right after lunch, kind of hit on some of those points. We're seeing, at the end of the day, the FHIR is a little simpler to deal with in what we're pulling in, but the content, it's pretty much the same fields. I think it's going to have to be the evolution of what fields are added. And on the provider side, what I hear a lot when they're like, oh, this is an exciting application that my user or my patients can just bring to me to bring in their records, they do want those physician notes, like they want to know what other physicians are thinking. From our beta testing, people are just excited when they get their data like that. Like, that's the exciting thing for them. They have a little bit of a lower standard of what they're looking for. I think there are people who are specifically looking for specific data sets, but people are just happy to not go through the hassle. I do think there needs to be an evolution on what data sets are going to be added to the fields as we progress in this space. Was that an answer to your question?
Yeah, I'm just kind of curious about, because it's something we, as an implementer, support of other use cases, we don't have full support out there. Where would you like us to invest more? Is the FHIR that our customers already have to support, and they do, a lot of them have connected with other apps, or is it more in the CCDs or Carequality?
I think a wider just spread of adoption of your client base is step number 1, because I think there's just some things are just really well documented, even within those specific fields. And I think if we can just get to a level of satisfaction there, then we can move into deeper fields. The biggest thing people want to see is notes. The imaging is very big, so I've seen some CCDAs that have like an image wrapped in them. So then there has to be like a viewer. There's lots of different variations. I also see weird, like it's either a CCDA wrapped in a PDF or a PDF wrapped in a CCDA. I can't really remember, but things like that, those aren't easy to deal with, but I'm just happy if people start adopting the use case.
At Wamba, we're FHIR enabled, and we see FHIR elements as the future from our perspective. So from our seats up here, I could say, as long as you can break down the data and you can share all of it, we're going to be happy in whatever you give it to us. But speaking for our particular company, we see FHIR as the future.
Bart, do you want to say something?
We do also, but I wanted to say something just in terms of how we store the patient's data when it gets in our system. When we created the company, we basically said, we looked at all the major EHR systems, et cetera, and said, we're not going to keep any identifying data in the same state as the clinical data. And we divide every piece of data as it comes in to different data centers purposely because of the things that we're talking about here. I haven't seen, now maybe there are out in the various providers, that level of separation. And then we back those up with other data centers in other states. So when a piece of data comes in from one of you on behalf of a patient request, we divide it. We take all the clinical data, we give it a secret code, and put it over in one data center. We take the other, your name, address, and everything else, and put it in another one. It's all encrypted. And I'm sure my cohorts here are doing similar kinds of things to protect the data. So
I think we have time for like one or two more questions. You had your hand up.
Thank you. I'm curious, I've worked in oncology for 11 years, and there's a large need to provide patients with more ease of going between specialists, even within their cancer care. What do your solutions do to help patients understand what some of the information means? That's my first question. My second question is, with getting a number of consults from different types of providers, is there any concern that some treatment plans that were not followed, that data may confuse providers further down the road? I know that I've had a number of examples where patients got maybe incorrect diagnoses or inadvisable treatment plans suggested.
I could talk about Morgan as more specific. So the two parts of your question was confusing treatment plans, and then what was the first part?
Giving patients information resources to understand what their data mean.
So information resources, yes. I don't understand half the things in my record. I don't know what it says, I don't know what it means, and I also see variations, just talking about the data that comes in like the formatting, normalizing the data to formatting it to, it makes sense because you can have penicillin written like 4 different ways. So education, yes, I think that's part of our job as applications, consumer-facing applications, is educating and using reliable resources. So whether you use an open API to like Medline Plus or something of that sort. And also, that's where user experience comes in a lot, like making it just really simple for people to understand. And also increases health literacy at the end of the day. Like everybody talks about people really engaging and being engaged in whatever their care plan is and following their care plan. If you don't understand it, you're not going to do it. And then when it comes to conflicting treatments or diagnoses, I think that is where the patient-doctor relationship comes in, and being able to have that data and kind of present it to your doctor, be like, I've tried this. Because usually at the end of the day, they're going to tell you it verbally and they're going to mess it up. So isn't it better if it actually has some sort of like clinical documentation and the data provenance hasn't been messed with? I don't have the answer, but I think it will start exposing itself in the coming years.
One more question up front here. Oh, you've got a mic. Okay. Well.
You're next. So,
Roland? Okay. Go ahead.
Yeah, so more of an elementary question. In terms of the current use case, Jennifer, how are the users authenticating themselves currently?
So, you guys can answer, sorry, if you want to.
Who was the question for?
Jennifer mentioned that Morgan has access to records and you're trying with other patients in other states, trying to get access to their own record through your platform. So how is that authentication working currently?
So this was a big problem for us when we were first getting started. It actually took us a long time to get started because of this. So we've created a couple of different flows. We also look at different state rules, like what constitutes a minor and when does those different ages kick in, and then I would love to see family sharing, but there's a lot of questions on that in different states. So this version, how we're doing it, is we're using Experian because it gets us to NIST LOA3, which I know has a different name now, but I'm going to stick with that. And when people can't get authenticated through that flow because they don't have a credit history or they're maybe part of a less fortunate socioeconomic class, whatever it is, we then can guide them through the OAuth flow, which allows them to, if they have their patient portal credentials. And then I've looked into a lot of solutions where it's, can we authenticate them? I think they mentioned on stage through like IDs and selfies and things of that sort. There's a company I know of called ID Me that has like 5 different levels. So I'm always looking for new partners. And I think as we grow, we're going to have to expand that. And that's why I said we should have more people working on ID proofing, because that is a big problem.
Anybody else want to comment on that?
I'll just say that Wamba's powered by me only, and before, and that's our biometric and authentication, and it covers a whole lot of different elements of both the Experian type questions as well as the government issued ID. It doesn't really matter what level you get. What matters is that you have a process and set of acceptable to LOLA 2 or LOLA 3, whatever the rules are, that you have it as an unbreakable rule before any records are requested, that you validate and you verify and you authenticate who's asking the questions and where they are. And the lady in the back who mentioned the oncology patients, it's oftentimes not possible for the patient themselves, whether it's me as a flight medic and a rescue pilot, to find myself with people that can't necessarily authenticate themselves on the front end, or patients with the whole conversation that we've had regarding proxy of somebody going and doing the authentication for them. As long as when they start this process, which is why I'm such a firm believer, create the authentication and the validation on the front end. Let's give the population at large in the United States the ability to have that completely comprehensive PHR that flows through their continuum of healthcare. And then for them to authenticate and get into it later, they don't need their ID. They don't need their wallet. They can be washed up on shore. And if they have their ability to authenticate created on the front end, they'll be able to access it on the back end. If they have a proxy and somebody to look after their records, then when they get too sick to be able to pull it themselves, somebody will be able to go and do this. But let's get the process, let's get this conversation going, and let's get the records flowing.
If we can't authenticate you, you can't create an account, and that's why we've tried to figure out other workflows. So if we can't authenticate you, they can't go through the Carequality workflow. They're never going to be able to query that direction. I think that that's actually an interesting work group that could be started to start vetting solutions and come up with better answers.
I never get told I've been patient. This is a first for me. This is for all 3 of you. Do any of you plan to offer services to your consumers to help them handle integrity or discrepancy issues? So the data that comes through, let's say that it was wrong, and they don't know how to follow the string back. Oftentimes, to your point, they didn't even know where it came from. I mean, that's what you're bringing together, is that, now I'm not saying they don't know where it came from, but do you plan to offer those type of services to your consumer to help them correct misinformation? Because I think that's prevalent out there more than anybody's really talking about.
So we've had this conversation multiple times, and the answer is yes. But data provenance is a very hot topic in our industry, as you can imagine. But it's the reverse. Data flow and everything we've heard up here is coming from all of the providers down to the consumer. But there's another true value which we haven't even tapped on, and that is a medium and a mechanism for patients themselves to be able to add critical components to their files. So if somebody's...
Yeah, but what I'm asking for is if the information they get isn't information they added, but it came in and it was, I asked for me and I got you. And I know, I'm like, well, this isn't me.
We will manage that process and then validate it and correct it.
We built it, we flag it.
And correct it?
We flag the data, and we can send it back to where it came from, so everybody in this room, and we give you reports on, like, this is incorrect. We don't let people touch the data provenance, because if we send it back out, since the platform is bi-directional, it won't be accepted back into your systems or through the flow. So we let people annotate, but they're only going to see it on the front end, and that's more of a conversational with their physician. But we do flag incorrect data because we let the consumer say, hey, this isn't right, and that's reporting we can give back. It's not rolled out in that people are working with us, but we figured the more data we have coming in, we should build a mechanism to handle that question.
That's great.
Bart, last word?
Similar answers here. We do the same thing. We let the user flag it. The user can opt to inform the source of it, and it's all about consumer choice.
I told you we'd save the best for last. Please join me in thanking our panelists.